Okay. Is that now? Okay, good evening. I'm Dr. Jonathan Fu, and welcome to FAM Surgery's live stream on Facebook. Very, very excited to be coming live to you. Hello, and I'm so glad you're joining us today. We're coming to you through this live stream so that you can stay home, stay safe, and stay healthy. We're on day 11 of the circuit breaker. I trust everyone is doing well. Together we can overcome this. Hi to Danelle, hi to Eliel for joining in, hi to Suying as well. If you're watching this right now, just let me know in the chat, type away if you are on the live stream, who you are and where you're catching this from. A big shout out to Singapore Cancer Society for supporting and partnering in this event. Thank you. A bit about myself. I'm a senior consultant general surgeon with FAM Surgery. I specialize in colorectal surgery. The bulk of my work involves scopes, laparoscopic or keyhole surgery, robotic operations, and procedures for the back passage, such as PALS. Now, this is the first part of a series of live streams that allow us to connect with you in the community. These sessions will help you better understand common conditions and how to get it treated. So do make sure you share this video with your friends and loved ones. So what are we going to cover in today's session? I'm going to talk about colorectal cancer. Yes, that's cancer of the large intestine, how it's diagnosed, treated, and more importantly, how to prevent it. And as the saying goes, prevention is better than cure. In fact, let's take a poll now. Anyone has any thoughts? Does colorectal cancer affect more men or more women? Let me know your thoughts in the chat. Type away and let's see what the results will be. As we get the responses rolling in, just to let you know, in the second half of this session, we're going to have a special guest, Mr. Eliel, join us to share his life-changing experience, so don't miss out on that. During the course of the talk, feel free to type in any burning questions that you have, and I will try to answer as many at various points throughout this session. Let's give some time for some of the responses to come in. Hi, Ivy. Big shout out to Angela, Li Hua. Vincent has come in. Zitra Chen has come in as well. Good to see you guys. Still waiting for some of the responses to come in. We'll collate these answers shortly before we move on to the talk. Okay, we have collated the response, and the overwhelming majority have indicated that it's a condition that afflicts men. Is that true? Well, I'll answer that question in the talk later on. Okay, so without further ado, let's get this session started. As I mentioned before, we're coming to you live so that you can stay home, stay safe, and stay healthy. Now let's move on and let's have a look at the cancer statistics within Singapore. Now, if we look at this slide, what you can notice from the slide, and it's very obvious, is that from 2011 all the way to 2015, we notice that there is an increasing trend in the number of new cases of cancer. And in terms of cancer, it doesn't really differentiate between genders, and it's approximately afflicting 50% men and approximately 50% women. All right. Now, I want you to, in particular, to keep in mind the numbers for 2015. The number of new cases during that time was 14,148. Now, fast forward to the statistics in 2018, and what we will see for 2018 statistics in the next slide are that the number of new cases has increased very significantly. If you remember just now, it was 14,000, but in 2018, this is now 26,000, and 13 of which there are 13,000 deaths in 2018 from cancer. Not specific to any cancer, but all comers. And similarly to 2015 as well, there's about a 25% chance that a local individual would be diagnosed with colorectal cancer before the age of 75. But why are we talking about colorectal cancer today? Because it is the top cancer within Singapore. Now, if we look at the next slide, what we will see is that it is the top, all right, among all the other common types of cancers within Singapore. If we further segregate this into males, what we will see is that for the males, this is actually the third most common cancer. In the next slide, we will see that for males, colorectal cancer is actually the third most common cancer. Now, this actually is important to note as well, because unlike prostate cancer and lung cancer, while it is the third most common, it can occur in any age group. Right? Notably, it does occur in patients more towards patients above the age of 50, but it can also occur in patients below the age of 50, unlike prostate cancer, which tends to affect an older generation. If you look at females, for the ladies, what we do notice, as unexpectedly, breast cancer is the most common cancer, but colorectal comes in a close second. Now, what is the colon exactly? As I mentioned before, the colon is a large intestine, but where exactly does it run? All right, now the colon actually starts from the right side, on the right lower aspect of the tummy. It starts around where the appendix is, in the right lower aspect, and it goes up and it swings across the tummy and it goes round to the left side before coming down and joining up to the back passage. Now that's a very long route, but that is essentially the large intestine, or the colon, and the rectum. Now, how does a cancer occur? If we look at it from perspective, nothing appears from a normal on the extreme left picture to something on the extreme right, which is a colon cancer. It takes time and doesn't happen over the course of one day, overnight. I've had patients who are diagnosed with cancer before, and after the news has been told to them, they're very shocked, naturally, and the immediate response was, how could this cancer occur within days? How can it cancer overnight? The fact is that it doesn't. It begins as a small polyp, as we can see in the center of the screen. Now, what is a polyp? A polyp is a growth where the tissues grow a bit more than normal. And over time, if these is left inside, the character and the nature of these polyps can actually change such that they can become something nasty, like a cancer, in the extreme right picture. Now, but are there things that we can do to reduce our risk? Certainly in life, there are things that we can modify and things that we have absolutely no control over. Things that we cannot absolutely modify would be our genetics. This would be our age, which family we are born into, what is our personal history like, what is our family history like with regards to cancer. So these are things that we cannot change. But if we have any of these risk factors, then we need to be mindful of what are the unusual symptoms that we should be aware of, or if we have reached a certain age, beyond the age of 50, or we have a certain threshold that we should be doing screening, we should proactively go and undergo screening tests. But what can we change? How can we empower ourselves to reduce our risk? What we can do is that there are about 6 factors that we can change. And if you notice in these 6 factors, this is very much related to pretty much a Western lifestyle, a busy lifestyle, and an affluent lifestyle. So we're looking at having diets that are high in processed meat, high in red meat, and we're also looking at lack of exercise because we're very busy in the workplace, or we are busy with e-gaming nowadays. And certainly smoking and alcohol consumption has become a very affluent form of lifestyle. So if you can take all these in moderation, or even cut out some of these factors, we can potentially reduce our colorectal cancer risk. Now, I've heard some of these signs and symptoms in the next slide that I'll come to. These are 3 things that I hear very commonly. I'm sure some of you perhaps have even said this yourself, or you may have even have friends or family members who have said this to you. But these things are what I consider myths, all right? Do you think it's true? To me, it's a myth, okay? The next slide, we'll examine it closer. Now, the fact is that none of those things in the previous slides were true. The fact is, the most common sign and symptom of colorectal cancer, when it's in the earliest possible stage, is that there are no signs or symptoms at all. The patient is completely asymptomatic. And in fact, they feel 100%. They feel perfectly well. They go about their daily activities. They can go for a run. They can go for a swim, play football with friends, not knowing that there is something sinister that is hiding inside the large intestine. And contrary to popular belief that the most common cause of blood in the stools is piles, blood is also the most common sign of colorectal cancer. It is a misconception that must be changed, that blood in the stools is almost exclusively due to piles. We have to change that mindset. And lastly, as we took the poll early on, colorectal cancer does not discriminate between gender. It affects males and females equally. So when should we be concerned? Are there any particular signs or symptoms that we should take note? Now, I put these 5 signs and symptoms in red because these are what I consider to be red flag symptoms, whether taken by itself or taken together. And even during this circuit breaker period, if you have any of these signs or symptoms, please seek medical attention, go and see a doctor and get it evaluated, because this could signify that there is an underlying more sinister process, or they signify there's a cancer that is going on inside the colon and the rectum. And early diagnosis and early treatment leads to best outcomes. But what happens, let's say, if the cancer has been diagnosed, looking at those symptoms? Now, this is a very, very busy slide, and this slide essentially highlights to you the complexities and the intricacies that are involved in dealing with cancer. So the key points to focus would be on the topmost portion. We're looking at workups as well as primary treatments. Now, if we look at workups, once a cancer has been diagnosed, the next step would be to work up. And what is the purpose of working up? The purpose of working up is to determine the stage of the cancer. All right, I'll come to that in the next slide. But the workup is very, very extensive. All right, there'll be a battery of blood tests. You need to do many scans, a CT scan, maybe an MRI scan. Certainly a PET scan needs to be done. All this is to determine how advanced or how early a cancer is. Now, this slide shows cancer staging, and colorectal cancer is pretty much similar to all the other cancers. Runs from stage 1 all the way to stage 4. Stage 1 being the earliest possible stage in cancer diagnosis, and stage 4 being the most advanced stage. Now, stage 4 implies that the cancer or the tumor has moved out of the target organ and has gone to other parts of the body. Most commonly in colorectal cancer, this means that the tumor has gone to the liver or the lung or liver. It may also have gone to the lining of the tummy itself. And why is it important to detect cancer in the early stage? As you can see, in stage 1 cancer, the 5-year survival exceeds 90%. And if we go all the way to the right, we notice that this number keeps decreasing as the cancer gets more and more advanced. So what are the treatment options that we have for colorectal cancer? It's not to say that this cancer is untreatable. The treatment options would involve surgery. This can be both for early and late stage. It depends on the clinical presentation of the patient. And it can be open surgery, traditional open surgery. It can be keyhole or laparoscopic and robotic or hybrid approach, combination of both. It may also involve chemotherapy and or radiotherapy, either before or after surgery, what we know as adjuvant chemoradiotherapy. And what do we do when we do surgery? There are various types of surgeries that we can do. As a brief introduction to it, the highlighted areas are the areas that we can remove. This depends on the location of the tumor, and we remove it's not just removing the tumor in itself, but we have to remove a segment of the large intestine together with where it drains into the blood vessels together with the lymph nodes so that we can obtain accurate staging of the cancer and we can have accurate and give you the best possible treatment. Now, on the next slide, we'll see something that a lot of patients, when they think of colorectal cancer, something that they are very fearful about, and that is the need to wear a bag or losing the bag passage altogether, particularly in rectal cancer. Now, this is known as a stoma. A stoma is an opening that is created in the abdominal wall, and that's where we attach the large intestine, the small intestine, to the abdominal wall, where the waste comes out through. Now, what you're seeing on the right picture is freshly created stoma, and that's without a bag. The next slide, you'll see if we put on a bag to cover the stoma, this is what it looks like. And do not worry, I've had patients who have had stomas before, and with today's technology in bags, and if you do put it properly, no one will actually know that the individual actually has got a stoma or has actually gone surgery where the anus is removed, where they are wearing a bag. Of course, people are concerned that does leakage occur? It can be pretty embarrassing. No doubt, I agree with that. Accidents can happen, but if we do take care and we seal it properly all around, accidents usually are few and far between. And of course, special care has to be taken when carrying a stoma bag onto a plane because of the pressure differences, and this can cause the bag to expand. All right, let's see if there are any questions that we need to address at this point in time. Big shout out to Olivia and Joanna Wong as well, and Janice who have just come in. Oh, Felicia is in as well. Hi there, Felicia. Big shout out to you. Okay, let me run through the questions and see what there are. We can answer a few questions at this point in time before we go on to what colorectal cancer screening involves. Let's see. Okay, Howard asked a question. High fiber diet can reduce all types of intestinal cancer. Well, Howard, I'm not sure if it reduces all types of cancer. I don't think that it reduces stomach cancer or even small intestinal cancer, but I wouldn't touch so much on small intestinal cancer because that is not common. I would say that it doesn't reduce stomach cancer, but it helps with colorectal cancer risk reduction, certainly. Okay, let's see what other questions are there. Can avoiding fried and preserved food greatly reduce cancer risk? I would say it's difficult to avoid completely. No doubt everyone enjoys like to have their taste buds tingle a little bit on and off here and now and then. But I would say that the key point is moderation. It's not to take these foods excessively or constantly in every single meal. Moderation is a good thing because bad things, you take it accumulates and it also becomes bad. Certainly, too much of a good thing can also be a bad thing. So, key thing is to balance the lifestyle of what we take in. There's another question. Do all colorectal cancer patients require a stoma? Now, the answer to that is no, not all colorectal cancer patients require a stoma. In fact, the need for a stoma depends on really the patient's clinical presentation, their past medical history, that means their medical problems when we are performing the surgery, whether or not, because that affects whether or not we can do a connection to join the colon and the rectum back together or join the pipings back together. Certain medical conditions, like if they're on kidney dialysis or they have very bad cardiac conditions, heart conditions, these may potentially preclude the ability to do a good connection point. In emergency surgeries, again, it's possible because the patient's physiology is affected, so we may not be able to join the large intestine at that point in time. Stomas come in two types. They can be permanent and can be temporary stomas. Permanent stomas are more related towards can be related more towards the lower rectal cancers, where I would have to remove the rectum in its entirety and the anus in its entirety. So we have to have a permanent stoma. For temporary stomas, these certainly can be reversed, so there's no need to wear a bag in the future. Okay, this time let's continue with the cancer screening first, and we'll take on some of the questions towards the end of this talk again. Now, colorectal cancer, to me, colorectal cancer screening, it's really, really important. And in fact, this to me really is the crux of today's talk. But why screen, really? We've talked previously about the diagnosis and treating the cancer, but why screen the cancer? Now, because screening in itself can prevent the cancer. As I mentioned before, prevention is always better than cure. If we can do a scope, we can find the polyp, we can remove the polyp, we can prevent the cancer in its entirety. And that is excellent. Now, colorectal screening itself is also cost effective. If we look at the cost, what the cost for a scope compared to the cost for cancer treatment, what does cancer treatment involve? Cancer treatment involves doing a workup to stage the cancer, and if you recall, that involves blood tests, scans, loads of scans, surgery, hospitalization, and even chemo or radiotherapy for 6 months or even longer. Now, that entire package adds up to a substantial cost compared to doing a one-off scope, which if it's completely normal and there's no need to do a scope for a period of time. Even if there are polyps that are removed, usually all that's required is a surveillance scope, which your doctor would advise you. And colorectal screening allows us to pick up cancers if there is a cancer, because when we go for screening, these patients are usually asymptomatic, they feel perfectly well, so which means that the cancer is small. And it allows us to pick up these small cancers in their early stage, which means it leads to an improved overall survival. And that's what we want for cancer patients, best possible chance at survival. So who should undergo cancer screening? Certainly cancer screening is not for everyone. We don't expect a fit 18-year-old to undergo cancer screening at 18. So MOH has come up with certain guidelines. Anyone who is above the age of 50 should undergo colorectal cancer screening. And if there is a family history of colorectal cancer, then this changes slightly. Then the previous point doesn't apply anymore. So I'll give you an example. So let's say there is a family where the father has been diagnosed with or was diagnosed with colorectal cancer at the age of 45. Does it mean that his children also follow MOH guidelines and we go and they start screening from the age of 50 and above? Well, the answer is no. They should start screening 10 years before their father was diagnosed with the cancer. So that means that they should start screening from the age of 35. Now, just a note to let you guys know, the US Cancer Task Force has actually modified some of these for the US citizens, where they now recommend screening from the age of 45 and above. Now, they lead a very westernized diet, and they have noticed that there is an increasing trend of patients below the age of 50 who are being diagnosed with colorectal cancer. So they have brought this down from 50 to the age of 45 in the year 2018. Now, this doesn't mean that we all go out and, US has adopted this, therefore we should also adopt this. But take certain points to note. If you do adopt a very westernized lifestyle, all right, perhaps this is something that you may want to consider, that perhaps 50 years old, you may want to consider screening earlier than 50 years of age, just to check it out and make sure that everything is fine. Now, for colorectal cancer, contrary to popular belief, there are a lot of people who think that it cannot happen to me. I have no family history. There are no genetics at all within my family, from my grandparents, great-grandparents, and so on and so forth. Now, if we look at it in this pie chart, the most important thing to take note is that most cancers are sporadic. The yellow part, sporadic, means it happens for the first time in the family. And this is approximately 60 to 70% of the cases. Hereditary cancers and those with particular syndromes, FAP, Lynch syndromes, these make up only about 1 to 5%, but those with a family history make up to about 10%. Again, I emphasize, most of the cancers occur for the first time. So what can happen if we do a colorectal scope, screening scope? What can happen during a scope is that if the scope, as I mentioned before, if the scope is completely normal, perfect. However, if there are polyps that are found, it's very simple. The polyp is removed, and your doctor will subsequently advise you when to do the next screening scope, the surveillance scope, to recheck that there are no new polyps within the colon itself. If there is a cancer that has been diagnosed, then this will fall back into the cancer workup and cancer treatment algorithm. Now, sometimes we do find that if the initial scope, the preparation to empty the colon is very poor, we would recommend to repeat the scope, because it means that the previous scope, the accuracy has been compromised, and therefore we are not able to rule out find things on the lining, changes in the lining of the colon, or find small polyps. Now, if I reference you again to the treatment for cancer, you can see why it is important to undergo screening, because if you see the next slide, and I emphasize again that cancer treatment is complex. It is a long journey. We want to avoid having to go through this long journey because it can be very, very stressful for people. So what are the modalities that we have available to us to undergo screening? Now, these tests, I'll lump it together. The first two, a colonoscopy and a flexible sigmoidoscopy, are what are referred to as scopes. These are considered as the gold standard. Why is it the gold standard? Because it allows your doctor, your surgeon, to look, besides looking into the internal aspect of the colon, they are also able to perform procedures to remove the polyp. So that's where the added benefit of a scope comes in. Now let's see, so what does a scope involve? Let's have a look at the video and see. So this is what a scope looks like. A camera would go from the back passage, go all the way in, and subsequently the camera is slowly withdrawn to examine the internal lining of the colon. Now, all this is done when the patient is kept comfortable, they are asleep, so that there will not be any discomfort during the scope. And they wake up, the scope is over, and they'll be given food to eat by the nurses. After a brief period of observation, this is usually done as a day case, they can go back on the same day. There's no need to stay overnight in hospital unless they have medical conditions which preclude this. Okay. Now, a much simpler test, or very simple, very, very basic test, is the FIT test, which you can see in the picture below with the pink and yellow tubes. Now, what is the FIT test? Now, this is a test which tests for the presence of blood within the stool. It doesn't differentiate between whether this is Powell's blood, blood from the polyp, or blood from the cancer. So that's an important point to take back. It doesn't differentiate between the different types of blood. And how is it done? So let's look at the video to see how it's done. So what we do is that to do the FIT test, you have to collect the stool onto a piece of paper so that the stool doesn't come into contact with the water. All right. We open the test kit like so. And what we do with that is that after collecting the stool, what we will do is that you would take the test kit and you would insert it into the stool at various points, 6 different areas. And after that, twist it back into the container, shake it with the reagent inside. There will usually be a self-milling envelope, and you would send this off in the post. Okay? So there is some of these test kits going around in the post, yes, with stuff inside, yeah. Okay? And the results would usually be sent to you by post. If you have done this with your doctor, then you'll be advised to come back for a review, or they will post to you your results as well. Okay. The last test that's available is the virtual CT scan. If you go back to the previous slide, the screening test. This is otherwise known as a CT colonography, like the diagram below. This uses, it's not just a CT scan, but it's a special type of CT scan that we still have to empty the bowels, exactly like a colonoscopy. So do not go away thinking that, oh, the bowel preparation is horrendous. If I do a CT scan, I don't have to drink. No. With this special CT scan, otherwise known as a virtual colonoscopy, the patient still has to drink medicine to empty out the colon so it is completely empty. Because now we are using a CT machine to use software algorithms to reconstruct what the internal aspect of the colon will look like. And of course, if the bowel prep is very poor, it will be very difficult to differentiate whether or not something that is potentially seen there is truly a polyp or is it a fecal residue. Of course, the drawback to a CT scan is that, again, similar to the FIT test, it is just a diagnostic test. It just gives you a result. If, for example, in this case, a suspected polyp is seen, the patient will have to undergo a colonoscopy to confirm or refute whether or not this polyp is there, which means emptying out your bowels a second time. So the question is, which do you prefer? Okay, so as I mentioned before, my take-home message to you guys, which is the most important thing, is that colorectal cancer can be prevented through screening. It is treatable and it is beatable. Okay, so don't sit on it. Get checked for colon cancer today. If you are well, get screened for colorectal cancer after the circuit breaker. If, however, you do have symptoms, please do not hang around and hope that it goes away. Please go and see your doctor during this period. Let's take some questions at this point in time. It's a big hi to Dinesh. Hi to Sheila as well. Big hi to Vu, my friend Vu, all the way viewing in from Vietnam. Hi there, bro. Okay, so Sheila has a question. Someone's got a question that you'll be turning 50 this year. Does it mean that you must check? Well, the long and short answer is yes. If you have not done it before, the answer is yes. You can pick any form of modality to go for the check. If you want to have more certainty, or if you're not afraid of the complications or the potential side effects of a scope, which usually are low, then the colonoscopy can be considered as it is a gold standard. It allows both a view of the internal aspect of the colon, and as well it allows the removal of a polyp or taking samples, a biopsy for testing, if there is a need to. If you feel that the colonoscopy is not for you, then the most basic test certainly is to get a FIT test done. That's to test for the presence of blood that you cannot see within the stool itself. Okay, a question has come as well. Does constipation lead to colorectal cancer? The answer would generally be no. In fact, I would say that do not compare your bowel habits to your neighbor or to your next or to your friends. Everyone's bowel habit is slightly different. Some patients move their bowels every day. Some move their bowels 3 times a day. Some do it once every 2 to 3 days. So the idea is not to compare the bowel habits, but the most important thing in terms of bowel habits really is, has it changed? So for example, let's say if normally you move your bowels 2 to 3 days once, every 2 to 3 days. If as of late, say, you notice that there is a change, you start moving it more frequently, say it becomes every day or every other day, or becomes 2 or 3 times a day, or there is a change such that it reverts, alternates between constipation and frequency of the bowel movement, then these are things that you need to have it checked out. So if you normally have slightly hard stools, or if you move bowels 2 to 3 times a day, that's not to say that you are completely abnormal, and no, that doesn't lead to colorectal cancer. But if you do find that, for example, your bowel habits are extraordinarily long, for example, I have some patients who actually have moved their bowels once every 2 weeks or once a month. Yes, don't be surprised. Yes, it can happen. Then these need to be checked up, because often they may have underlying physiological conditions, anatomical conditions that predispose them to functional bowel diseases rather than a cancer. Okay, I'll take a last question at this point in time before I bring on our guest. What is the survival rate if you are diagnosed with stage 3 colorectal cancer? Again, it really depends, because stage 3, it depends on the age in which you are diagnosed. It depends on your medical problems. Does the patient go through adjuvant chemotherapy as recommended by the oncologist? Are you fit to go through chemotherapy? So there are a whole host of factors, but in general, I would say that for stage 3 colorectal cancer, we are looking at a survival rate of 5-year survival rate of anywhere between 50 to about 70%. All right. Okay. So at this point in time, I think let's move on. We have a very guest who's very, very eager to come on at this point in time. Let me introduce you to him. Some background to Mr. Alil. He is a rectal cancer survivor, all right? But not just any cancer survivor, but someone who is, as of this year, as he has remained disease-free for the last 9 years. Mr. Alil has since dedicated much of his time to helping those afflicted with cancer. He is a volunteer leader in various colorectal cancer support groups and is one of the founding members of the Ostomy Association of Singapore. Please give Mr. Alil a warm welcome.
Thank you very much, Dr. Fu, for that wonderful introduction. Hi, everyone. I'm very happy to be invited to be in this Facebook program, and I'm happy to share with you my journey.
Hi, Alil. How are you doing today?
I'm doing great, sir. How are you?
I'm very well, thank you. Excellent. Okay, Alil, could you share with us how did you find out that you had colorectal cancer?
Right. Actually, I can relate a lot to what you had just said earlier. There were symptoms very early on, almost like a year before. The narrowing of the stools, change in bowel habits. But then I put it down to maybe piles or whatever. And then I did self-medication, go to the
okay.
guy.
So you thought it was possibly piles as well?
That's right. And that's very true. And I was already almost 50 then.
All right, okay.
And I ignored those symptoms, self-medicated.
Okay.
And I only got really worried when there was a lot of blood flowing out when I passed motion. Right? So naturally, you see blood flowing out when you go to the toilet, you get really worried, and that's when I went to have it checked.
Yes.
And so they did a colonoscopy.
Yes.
And that is when it was discovered that I had rectal cancer.
Rectal cancer, okay.
Yeah. So it was a scope and a CT scan, and they did the staging. It was between stage 2 and 3. A couple of lymph nodes were involved.
Right.
So that was how it was diagnosed.
Okay. And did you have to have I understand that you required a permanent stoma following surgery.
Okay, that's right. So the treatment plan was to have surgery, and because the tumor was very close to the anus,
right,
they had to remove the whole anus and create a stoma.
Okay.
And it is a permanent stoma, right? So I wear a bag every day to discharge my stool.
Okay.
And after that, I had to go for adjuvant therapy as well, which means I did 28 cycles of radiation.
Okay.
And of course, they had the side effects, raw skin, nausea, irritability, and like that. Okay. And that was followed by 28 cycles of chemotherapy.
Right, okay.
Right? So chemotherapy, same thing, vomiting, diarrhea, irritability.
So it took you about 6 months, the chemotherapy?
The entire treatment was about 6 months, but something I would like to reassure for those who, touch wood, need to go for the treatment.
Yes.
Chemotherapy for colorectal cancer does not lead to hair loss.
Yes.
So the hair loss that you see here is a fashion statement.
Yes, that's right. So very important to the ladies out there, chemotherapy for colorectal cancer does not result in hair loss. Right. Okay, Mr. Alil, the other thing I was going to ask you. So you had a permanent stoma, which to many patients who, some of them may be tuning in, who have just had a fresh stoma, is a hassle. And I've had patients as well who have gone into depression about having a stoma and managing a stoma, in fact. What was your experience with managing a stoma, and how did this impact your life?
Right. So initially, yes, it was quite worrying that I had to manage this thing, and I used to be fairly active.
Right.
And one of the main concerns was how I was going to be, how I was going to carry on with my active lifestyle.
Get back to your usual lifestyle, yeah?
That's right.
Okay.
So what happened was I decided not to let it affect my lifestyle too much, right? So if you can look at some of the pictures that I've brought along, what I do now, I'm just going to try and describe what my lifestyle is after I realize that I have a stoma and how I manage with it, right? So I'm a very active volunteer. One of the main organizations that I volunteer with is the Singapore Cancer Society.
Yes.
All right. And I also am very active in physical sports. As you can see from the next slide again, I mean, the next picture, I do cycling, I do dragon boating, I do kayaking, I do Zumba.
Zumba, okay.
Right? And also to send a message out there to cancer patients in general and patients with stoma in particular,
Yes.
I do charity expeditions. In the next picture, you can see the group that I did this with.
Right.
In 2018, I actually went with this group to the Gobi Desert. 6 days of trekking in plus 40 degrees centigrade, right?
Well done.
And managing the stoma in the desert. So the message was, look, you can do stuff after you have a stoma, right? And if you see me in the street, right, nobody will know that I have a stoma. They see the things, the kind of things I'm doing. Right. So this is in relation to something you mentioned earlier.
Yes, no one actually knows that you're wearing a bag. Yeah.
That's right. So that was the Gobi Desert. And then the next picture, you see me actually being helped along a very treacherous slope in northern Mongolia. The temperatures were minus 35 to minus 50 degrees.
Wow, fantastic.
Right? And we had to hike in knee-deep snow. And yeah, so you can do all these things. And traveling is not a problem. You get used to it. I've been to New York, you know, almost 24 hours flying. No issues at all.
Yeah, right? Great.
So, yeah, and this is one of my favorite pictures, you know. It's a nice shot because it showed me quite garang, you know, using the ski and all that.
Yeah, it's great. Well done. I think you've done excellent. Okay. Lastly, do you have any advice for our viewers tuning in? Any parting words for them?
Yes, I think many of them echo what you have already mentioned.
Yes.
Number one, colorectal cancer is one of the most preventable cancers, right? So a healthy lifestyle, balanced diet, enough exercise, enough sleep, plenty of water, prevention number one. Number two is the screening. It is so important to screen. The moment you have changed your bowel habits, any slight indication that there's something wrong, go see a doctor, especially if you are already nearing your 50s.
Correct.
Right? Because then there's so many possibilities. I mean, you don't even have to maybe, get treatment. And yeah, it can be reversed. And if you do, touch wood, get diagnosed with cancer, then it's not the end of life.
Yes.
There is so much support out there. There are so many people willing to hold your hand and walk the journey with you.
It's great.
So just reach out. And yeah, I think basically that's it. So prevention, number one. Number two, get screened.
Yes.
Number three, if you get diagnosed, there's plenty of help out there. So don't worry.
Okay. Right? Great. Excellent words of advice. And thank you for joining us today, Mr. Alil.
Thanks, Dr. Fu, for having me on.
All right. Take care and stay safe.
Bye-bye. Stay safe.
Bye
stay home. Goodbye.
Okay. Certainly very reassuring words from Mr. Alil. Like I say, big shout out now. Big shout out to Dr. Samir, all the way coming from Dhaka. Shout out to Dr. Fu as well, PhD, coming all the way from Vietnam, Ho Chi Minh City. Hi to Sam. Hi to RK. Hi to Jolyn. Thanks for joining in. So remember, if anything, the biggest takeaway message I have for you is this: that colorectal cancer is preventable, it is treatable, and it is beatable. So empower yourselves today. Right. Now, this pretty much, let's see, any further questions we can take at some point at this time? We can take some at this time now. Let's see. Okay, there was a question about, not specific to colorectal cancer, but about PALS, that for a lady who's currently pregnant, should she have undergo surgery for PALS before getting a baby? Oh, it's my good friend, Mr. Ned, all the way from Cambodia. Good to see you here as well. Okay, I think for pregnancy, if the piles are not causing problems, the best would be not to do anything, because when we undergo surgery for piles and all that, it still involves some form of anesthesia. So I certainly definitely would not recommend it in the first or second trimester. Even the third trimester, if it can be avoided, I would say we should try and avoid it. What is very important, all women to a certain extent do get some element of constipation because the womb has enlarged with the fetus in the internal aspect, and that is compressing on the rectum. So there is a certain element of constipation. What we can do is to drink plenty of fluids, and if need to, take some laxatives. One of these would be liquid paraffin laxatives, because this is not absorbed by the body. We try as much not to take chemicals that are absorbed and potentially can be passed on to the unborn child. In the extreme scenario that the piles are very bad, that there's ulceration, it's bleeding torrentially away again, then unfortunately in that scenario, then certainly surgery would have to be considered, because then that would be used to alleviate the pain from the condition itself, and if there's excessive bleeding, that could potentially be life-threatening, because piles, the mother has a very hyperdynamic circulation, meaning there's increased volume, so bleeding can always be a lot more, and if there's a lot of bleeding, that can be life-threatening, that can lead to a change in the blood pressure, and that can affect the fetus as well. So I would say only in that circumstance do we want to have surgery done for piles in a pregnant lady. Okay, let's see. Is FIT test effective since detection of blood is already at the later stage of cancer? Okay, in the late stage of cancer, as I mentioned before, patients would already see blood coming out. So they are not asymptomatic. They are already having symptoms from the cancer itself. In this scenario, there is no need to do a FIT test, right? Do a FIT test, or consider doing a FIT test, only if you are perfectly well, that is, you have no symptoms at all. So does a FIT test usually pick up a late stage cancer? Usually the answer is no, because tumors which are small, and these would usually be early tumors, they do not present with signs and symptoms of bleeding, but what they can present with is microscopic blood, or what we call as occult blood, where these can only be picked up with tests like the FIT test. All right, and usually, if it's picked up through screening, usually the cancer is usually that of an earlier stage rather than a late stage cancer. Okay, Okay, I'll take one last question here. A lady has asked, does using enemas daily lead to colorectal cancer? Now, in general, the answer is no. It's a medication that's used to empty out. Enema is a medicine that is, for those who are not aware what it is a medicine that is usually in a tube, like a syringe-like tube, and that is inserted through the back passage, where the medication of a certain fixed volume is pumped into the rectum. Patients hold it for a period of time before they expel. They have that sensation to move their bowels. So in general, it doesn't. But the more important question I would have is, why are you using an enema every day? Is there a particular reason for this? Because if there is, if you do having a serious issue with moving the bowels, you may wish to see your surgeon, your colorectal surgeon, to have this addressed rather than using an enema all the time. Or some patients even use stuff like coffee enemas, which is not something that we should be using. Okay, so I think that's all the questions that we have. That's all the time that we have for today. And this brings us almost to the end of today's live stream. I hope it was useful for everyone. Thank you for joining us, and thank you for your questions and comments. Sorry if I didn't get around to answering all of your questions in this particular live stream, or acknowledging all and everyone here. I'll be here again on the 27th of April at 8 p.m., same time, same place, where I'll be having two special guests, Mr. Derek Ong from Eat Right Nutrition Consultancy and Dr. Belinda Ting from Performance Sports and Rehab Specialists. Join me as we explore dietary and physiotherapy exercise aspects in cancer prevention. and how we can strengthen ourselves during this period. Our supporting partner, Singapore Cancer Society, has kindly provided 50 complimentary test kits to us. These will be available at our clinic at McPherson Mall for yourself or your loved ones. Should you wish to collect on their behalf, please bring along their ICs for identification after this circuit breaker is over. If you enjoyed today's live stream, do give us a like, share, and subscribe for our upcoming session. If there's anything else that you might be interested in, do drop us a message or an email. I greatly appreciate your time today, and I will see you in the next stream. Remember, stay home, stay safe, and stay healthy. Till the next session, take care.